because it points out, without saying it, that hierarchy is a leading cause of patient harm, right? People are afraid to speak out because of hierarchy.
Welcome back to the podcast for doctors by doctors. I'm Dr. Michael Jerkins.
And I'm Dr. Ned Palmer. Thanks for joining us today. Michael, how you doing?
I think I'm pretty good. I'd say average. About I don't know, 7 out of 10.
That's pretty good. That is maybe, if you're split sometimes between being an internist and a pediatrician, I want you to know that I am average, and then giving it a scoring system is pretty internal medicine. That is.
What if I said I'm a slightly upturned smiley face? Would that be more pediatrics?
Yeah. I mean, you just emojied it, so I think that is by definition in some ways.
There you go. So it just depends.
You contain multitudes. I appreciate that about
The
you.
beauty of med peds, as we say. Sarcasm with hugs. Another way we say it.
Sarcasm with hugs. What was the other one? Who's on the shirt?
I don't know. I only remember that one, which actually, I think, Ned, is a pretty good segue to our guest today. It was not planned, by the way. This segue was not planned, but someone
It's even better
who
when
writes.
It's not.
That's right. It's much better. It's really incredible. I think over the last, maybe it's just where I'm at in my career, I'm more attuned to people talking about these issues. But I do feel like there's a lot of progress and a lot of voices now speaking on some of the issues that doctors face today on communication, on medical error, on the emotional toll that doctors face treating patients. And Dr. Ofri, who we have on the show today, is probably one of the foremost voices on those topics. So I don't know how she feels about sarcasm, but probably not the best way to communicate, I would guess. But I'm really excited to be able to talk with her.
I can't wait to ask her about how humor injects into medicine. No, I've been following Dr. Ofri's research for quite a while, right? I think she's written maybe more than 6 or 7 books at this point. One of the many hats that you and I wear that you all know is one that I'm deeply interested in, is in ethics and bioethics as it injects into medicine. We've absolutely used Dr. Ofri's work before, spoken through some of the books and the writings that she's done, some of her work in the New Yorker, on what are the ethical requirements and duties of a physician. How do we communicate about harm to each other? How do we communicate to other physicians? How do we communicate to patients about it? It's really a wonderful world, because ultimately what that all goes back to is supporting doctors. It's not harm through the interest of punitive behavior and of lashing out at doctors. It's how do you protect yourself, knowing you're in an industry where even the best decision can cause harm, even the right decision can cause harm. Even if you use a scoring system, like how am I doing today from 0 to 10? That's just a probabilistic measure. It's not going to be completely accurate. And we need to be comfortable with these things working in something as complex as medicine. I'm incredibly excited to talk about it.
Yeah, well, let's get to the interview with Dr. Ofri.
Dr. Danielle Ofri is one of the foremost voices in the medical world today, speaking passionately about the doctor-patient relationship and bringing humanity back to healthcare. She's a practicing internist at Bellevue Hospital, the nation's oldest public hospital. She's a clinical professor of medicine at NYU. She's also the founder and editor-in-chief of the award-winning journal Bellevue Literary Review. Her writing appears in the New Yorker, the New York Times, Slate Magazine, The Lancet, New England Journal of Medicine, as well as the Best American Essays and Best American Science Writing. She has performed stories for The Moth, and her TED Talks include Deconstructing Perfection and Fear, a Necessary Emotion. A recipient of a Guggenheim Fellowship, the National Humanism in Medicine Medal from the Gold Foundation, and an honorary doctorate of letters, Dr. Ofri is the author of 6 books about life in medicine. Her newest book is When We Do Harm, A Doctor Confronts Medical Error. As an ever-struggling student of the cello, she's well acquainted with error and excited to talk to us today. Just like we're excited to have you here. Unequivocally, our most published guest on this podcast thus far, Dr. Ofri. Thank you so much for joining us today.
Thank you. It's a pleasure to be here.
I'd love to dive into medical errors. Let's start with the fun bits. Let's lay it all out right up front. I remember having gone through training now 10 years ago. Medical errors were this thing that we lived in fear of this sense where you'll make an error, you're gonna flame out, it's gonna compromise your career, you're not gonna get through. Like it was just all seen through this fear and this punitive sense. But I'd love to step back. I feel like I've got an evolved sense of where we stand with medical errors, but you're the specialist, and so my opinions just genuinely aren't as valuable as yours. So please, I want you to talk to us about where you see are some of the problems in the U.S. healthcare system in how we deal with medical errors, and frankly, some of your own interest, how you came to develop a passion in this space.
Sure. Well, I'll preface this by saying I'm actually not an expert. There are people who really are experts in the field. So I come to it like you do. I'm a primary care doctor. And I came to it when that article came out in the BMJ about medical error being the third leading cause of death. And my publisher sent me a note saying, "Is this really true?" And the truth is, I didn't know the answer. I thought,
Mhm.
I work in a busy public hospital. If medical error is the third leading cause of death, I should be seeing tons of it, right? Almost as much heart disease and cancer they see, which is a lot, but I'm not. So either the data are wrong or we simply have blinders on. And that's kind of how the book came to be. We could talk for an hour about the pluses and minuses of that analysis. Short answer is probably not the third leading cause of death, but it's not a small thing. There are a lot of errors in it. But what I think that I've come to understand, I think we as a field understand, we really want to broaden the idea. We think about medical error, okay, you amputate the wrong leg. Well, that's an error. But there's lots of things that fall into this gray zone, right? About whether it was truly an error. Did the error cause the death? Like imagine you have a patient with cirrhosis who gets the wrong antibiotic and they die. Well, there was a mistake. Did the mistake cause the death? The patient already has cirrhosis.
Mhm.
I mean, most patients who have quote medical errors are pretty sick and have many things going on. So which is partly why we can't answer the question so well, because it's very hard to pick out an error and what the error caused in these patients with just many, many things going on. Nevertheless, I feel like we've moved ahead in terms of thinking about patient harm, right? If you're the patient, does it really matter if it was an intentional error or oversight or judgment call? If you've been harmed, if you're in renal failure on dialysis now, it doesn't really matter, honestly. So we really want to treat all patient harm together. If you get a decubitus ulcer, whether the nurse didn't turn you enough or it was just bad outcomes, whatever, it's still a bad decub ulcer.
Mhm.
So thinking about patient harm lets us broaden the lens, both in the way we tally the number of things that go wrong, but also how we approach them. Because if we're just sort of chasing down those bad apples who are, sloughing off in the end, we're really catching just a small bit. Like and we
Mhm.
all know tons of those near misses, sort of errors, didn't quite go.
Mhm.
Glad the
Yeah,
patient did
yeah.
okay. More than we want to even like admit in public. But that's really where we want to be going because those are the minefields. And so if we just focus on the
Mhm.
person who amputated the wrong leg or put the wrong IV fluid, we are missing this enormous place that where patients potentially could be harmed. So thinking more
Mhm.
generally, less punitively, I think helps us a lot. And I'll stop there because I could talk on for an hour on that.
Yeah, well, I think we're gonna, and I'm excited. So, I mean, if I heard you hit on something kind of right there in the beginning, there's really like a fundamental difference between, a patient dying with an error and dying of an error, or experiencing something. It's kind of that like with or of distinction. Am I tracking that correctly? Just through the first part of what you were describing there,
Right. And it's just very hard to know.
the causality component, right? Of like, especially when you do a chart dive, right? Because there's always that question of these are post hoc analyses. You're looking back, typically through a chart review. How much of that represents the reality of what was actually going on in the patient with the patient, in that moment at that bedside encounter? So there's almost like layers of obfuscation in a way that make this really difficult to unpack.
Right. I also think that when people look at medical error from the outside, they really have no concept what it's like inside when you're taking care of a sick patient. Right? When you're in the hospital and the patient's got 16 medical issues, they're on 55 medications and drips, and and you've got 20 consultants on the case. There is so much going on that to pin out or tease out one thing, and
Hmm.
that was what like made that feel good. It's almost impossible. I mean,
Yeah.
occasionally you see it, they grab the wrong syringe, but 98% of the time, it's just this amalgam of all these things. There's bad luck, there's bad outcomes, there's bad disease, and there's just
Hmm.
that go on. And to pick it all out, it becomes a little bit, I mean, it's important to try and figure out what we can prevent, but sometimes we just chase our tails trying to tease out the one thing we can blame. And that just gets us nowhere and just a huge waste of energy.
Hmm. Completely. So in your initial answer, you mentioned that there's a history to medical errors, right? So I think we're coming up on the 25th, or we just passed the 25th anniversary of To Err is Human. Groundbreaking research from late 99, I think it came out. Really, I think ignited this talking point, or this factoid, that a third of patients are suffering this, or I'm sorry, it's a third leading cause of injuries. Like you said, that we've started to change the language around harm. What other changes have you seen that healthcare has kind of molded or adapted to since? I really do consider that kind of like a really groundbreaking piece of literature in the field of healthcare.
Sure. And so I think the other thing, we're trying to be less punitive, but trying to figure out what situation made this error or bad outcome more likely to happen, right? You could say, yes, the nurse grabbed the wrong bag of fluid, and that was an error. But do all the bags of fluids look alike? Are they all stacked in a room with poor lighting? Does the nurse have too many patients to take care of? So yes, that person, maybe they did make an error, but there's always things that make the error more or less likely. I mean, think about look like, sound like medications, syringes, a
Hmm.
thousand and one things, overworked people, that there are things we can do to lessen the probability of things going wrong. And sometimes, we get on this thing about, oh, we want zero medical error or eradicate it all, vision zero. Great on a bumper sticker or on a grant application, but really not realistic, right? If we're going to get, if there's going to be zero error, that means someone's fudging the data, right? It's not going to happen. We're human. So can we think about error mitigation? Can we make healthcare more safe for patients and make fewer, you know, danger zones for people? So looking at what were the circumstances that made this more likely to happen here? And I think that's a more fruitful area of investigation. I mean, sure, you can fire the nurse, you can fire the doctor. If you fire everyone who messed up, there's no one left. So that's an
Yeah,
adverse outcome for patients, right? We have nobody left.
completely.
And who's going to talk? Who's going to own up? If we thrash everyone, no one's going to talk about all those near misses and that almost happened. I saw that happen. Who's going to speak up if they're going to get humiliated and fired? So changing that to
Hmm.
be a little less litigious, a little bit like, how do we make patient care safer for the patients?
Hmm.
And I'll say for the practitioners of medicine, because there's lots of harms that happen to, how many people have gotten like stuck with needles and to say nothing of all the psychological harms and things that happen. But I think we can
Hmm.
make healthcare safer for everyone involved.
I mean, I have to imagine we can, right? Like working
Right.
together. And I think there's been some really massive improvements in the way healthcare addresses these things. Danger zones is one that I've seen, but I was wondering if you could explain that and kind of talk through what danger zones are and the risks that come out of it. 'Cause it's a term I'm lucky enough to be familiar with, but I don't know if everybody is. I know it from inpatient medicine as well. And so if there's an outpatient version, it's
I didn't even know it was a real term. I think that way. But here's an example. Like in the OR, right? There are all these tubes of gas for a patient. The anesthesiologist has to hook up, right? Oxygen, nitrogen, all
yeah.
and so if you mix them up, which occasionally happens, the patient can die. These are very serious gases. So they first said, well, let's make them color coded. But of course, there's still some times it gets mixed up and you're going fast. They finally made the valves and the tubes different sizes. So you can't actually mix them up, right? It's not rocket science. And think about your food processor. You can't turn it on if it isn't locked. So idiots like us don't stick their fingers in, right? It prevents you. So there's so many things we can do to make it dangerous, right? A food processor is a huge danger zone, but we can make it safer by, having those safety things, the cars that don't turn on until you put the seatbelt on, all kinds of things that you can do. That's one. I'm thinking about, heparin. We have a different concentration of heparin for a heparin flush on an IV versus heparin intravenous heparin. And if you do the wrong thing, you could really damage someone. Why do we have them anywhere near each other or looking like or sounding alike? They should be, or epinephrine, 1 to 1,000, 1 to 10,000. All these things that I still don't remember the difference, but I have to look it up every time. Why do we even, have these things so close together? And don't get me started on like sound alike medications. There's so many out there, and it's really we can do better. They try to capitalize too. Why is it they even allow it to have a name that sounds? Why is Lamisil and Lamictal look so much alike? And
Yes.
antifungal, anti-seizure. You don't want to mix those up, guys. So lots of things we can do.
Absolutely. And I think speaking of things we can do, I'm curious on what you've seen done over the years in residency training or medical school, specifically on how doctors should be trained to think about medical error and or talk about it openly. Have you seen much evolution there in how we're training doctors to deal with this?
Well, I do see now that we have kind of a new generation of doctors who are the attendings for those, because the attendings for us were kind of a generation a little bit bygone that was this perfection doctor, you're perfection, either you're a perfect doctor or you go work for the pharmaceutical industry, or there's nothing in between, right? It's perfection or failure. And so I think we've gotten a bit out of that mindset. And so we have many more doctors who are more comfortable talking about their errors. So seeing attendings who talk to their team on day one, here are the like top 5 errors I've made, the big ones. I'll spare you the other 50, right? And so when you make it your first error, not if, but when it happens, you will come talk to me, because I'm not going to scream at you or throw you out of the program or give you a bad
Mhm, mhm.
recommendation. And to model that, kind of coming from the top, that's much more common now. I don't think I ever heard an attending tell me about error at all or their errors. No one's just till he got to M&M and got screamed at, by the division chief, and it was always the intern up at M&M. I've also seen M&Ms now where more senior people, come up to the stand. So not just the intern, but the division chief, the attending. We can all talk about this together. It's really this sort of team issue and not the one person that we flay on the stand. So that's really been, I think, a salutary change that we've seen in medical education.
Yeah, and I think that it's interesting to the whole modeling aspect of this, right? If you don't see someone be able to model that in training, it's hard for you to understand how to do it. And I think about um, being transparent as an attending to trainees about things you had to brush up on or things you weren't sure and had to go ask a colleague or a consultant or read more about. Like, the purpose of training isn't to know everything, because nobody does, but the purpose is to be able to understand where you could look up things and how to treat patients, and get the answers when you look them up. I think um, Ned and I talk a lot about this, especially in the summer months, July, August, or so. Um,
Mm.
it's really refreshing when you have interns or trainees that are unafraid to say, "I don't know, but let me find out." And that transparency and willingness to, um, admit when you have questions or admit when something didn't go exactly right. I think patients are much safer because of that. Echoing all the things you said, I'm sure you discovered in your research too.
I'm wondering, do you remember any attending modeling, taking you to the bedside and talking to a patient about a bad outcome? I don't remember that. And I think if I'd seen that, I'd remember that. I mean, the 50 kinds of vasculitis, those are gone. But an attending showing us, how do you talk about a bad outcome or a mistake to a patient, to a family? That's a lesson that we really,
Mhm.
it needs to be modeled. You can't learn that on PowerPoint or in a textbook. You
Yeah.
really have to see it being done sensitively and thoughtfully.
I'll tell you, I remember in first aid step one, there was an acronym for how to break bad news. Because they would test you a multiple choice question on maybe one of the most complex things that we struggle with every day.
Right,
And it was the SPIKES acronym. I still remember the acronym. I don't know what it stands for, but I remember the letters behind it.
right.
But that was totally external. It was through this lens of, oh, we came across this devastating diagnosis. We came across some new finding. It was all through the lens of, we're doing everything right and we're disclosing bad news. So there was still no internal reflection of, bad news could be because of a bad outcome, because of a mistake or an error, or again, even our best intentions, but still. So it, I remember that level of training is the only piece that we ever actually had. And it had nothing to do with error.
When you actually saw an attending break bad news to a patient in a very humane and empathetic way, that I
Yeah.
remember those, those really stand up because that's my role model.
Yeah. I think some days I'm still channeling that,
Right.
like if I'm just parroting those experiences that I saw that worked, right? Like, so I think the training is really critical to this. So have you seen more formalized training start to work its way into, for instance, more med peds or internists, like into some of the training programs, residency programs? Are there more formal structures behind it?
I can't speak. I'm not, detailedly involved in the training programs. I mean, I work with the residents. I mean, I think there's definitely a little bit more, talking about the sort of non-litigious way of approaching that, and the sort of Swiss cheese model, looking for the many things that happen to make this possible. But I do think certainly the M&Ms that I've witnessed are much, much less litigious appearing. They're
Mm,
much more about, let's figure this out together, and not, who can we crucify up there. And I think that in itself is an incredible gift to our trainees, because they see us. How do we wrestle with, because things always go wrong. And the other side of the equation is educating the public that, medicine is not perfection. It is not ordering from Amazon. It is far more complex. And, we make these comparisons to the aviation industry all the time, but there's a finite number of airplanes out there, right? there's infinite number of humans, crossed with their diseases and how they present and their psychosocial overlays. There's so many more possibilities in the realm of human beings and their illnesses, um, that we can't apply the same sort of checklist. It doesn't quite work. And I think people have this expectation that there's going to be a perfection. And so talking more openly to patients about uncertainty, probabilities of diagnosis, the
Mm-hmm.
ambiguous nature of a test result. People think, oh, it's a yes, no, a stress test, yes, no, but no, there's a probability and there's a Bayes theorems, all these things that helping them understand that is another, big part of the equation.
Can I ask real quick? Because we might have some people that are listening that don't know what M&M is. I know all three of us have experienced them, for better or worse. Can you explain to the audience who listening what that is and how it's used?
So M&M stands for morbidity and mortality rounds, all the things that go wrong, that harm a patient or kill a patient. And so once a month, most departments will pick a case where something didn't go well and have a formal presentation, the case, it's discussed, what went wrong, how do we fix it. Yeah, in the past, usually someone is kind of like a trial, someone was up on the stand. And I can tell you about my first M&M, which I remember so vividly. I was in surgery, my surgery rotation, and we're in this big conference room. The tier and the chief of services at the bottom, and it was this Texan guy, petite guy with a huge Texan personality. He scared the bejesus out of everyone, and I mean, even like the attendings quaked, or the deans when he walked by, and the residents would flatline when he called them on him. Patients loved him; they worshipped him. And there was an error, and I don't even remember what it was, but he like points to the last one and says, "It has that resident stand up," and then he says, and I can't quite do his marbles in the mouth thing, but he says, why even operate? Just take the guy out to the parking lot with a rifle and shoot the guy. Why even operate? and I remember the
Why?
resident turns this shade of gray. I'm going to go, we're going to be calling a code soon. But I'm a medical student. I'm there to learn. And I learned three things that day. One is I am never making an error. I got to be the best doctor ever.
Mm-hmm.
And two, if I make an error, I am not telling anyone. Otherwise, I'll be getting screamed at by Dr. Spencer. And the third is I'm not going out the parking lot. I don't know what the Department of Surgery is doing out there, but I am staying clear of there. So it really, like, it stayed with me all these years later. That's how we learn about medical error. And I think that we've really now evolved from that, that, I don't know what that resident did. I'm sure she didn't kill the patient, viciously, that whatever it was, who even knows, but it certainly doesn't make you want to like talk openly about places where you fall short as a physician.
Absolutely. The program that Ned and I trained at, also it was called MMI.
Mhm.
So morbidity, mortality, and improvement. So it
Mhm.
was supposed to focus at the end on the improvement piece, which didn't always occupy a large amount of time in the conference, but it at least was nice that they were acknowledging, okay, we're doing this to get better for improvement, for better patient care, which was nice. But I have similar traumatic M&M stories from medical school and residency. And actually, it's funny, is medical school similar? It was trauma surgery. Or actually OB-GYN was pretty tough for me too. But
So, yep.
um, Ned, I don't know if you have
Gen surge. Gen
general
surge.
surgery.
Big shocker there. Yeah.
I say the biggest nod to humanity was one time they took, those bins where they do suction out fluid, you know, a clean one, and filled it with peanut M&Ms and passed it out in the audience, and that was like being humane to everyone.
That's their way of lightening the atmosphere, huh? It's just, I think it's fascinating what you said about like how you have these anchoring moments in your
Mhm.
training, right? That really just
Mhm.
kind of draw it down. I still remember my first and still probably one of the most traumatic M&Ms that I've ever seen, general
Mhm.
surgery. It was for a patient who'd gone into AFib with RVR, post-operative. It was a big open laparotomy surgery. It was a big surgery, and they went into AFib with RVR. I spent years thinking that was the worst thing that could happen to a patient. And so you then go into internal medicine and you're like,
Yeah.
I mean, that's probably once a night you're dealing with a patient going into AFib with RVR. Right? Like that was, I mean, when you're carrying the pagers, you're going to get that call. My first job, I don't even think Michael knows this when we were interns together. Every time I got that call, I was like, they're dying. They're dead. Like this is already the worst thing that's ever happened. It took years to disabuse me of this notion of like how horrible this was because of the way that resident was treated presenting on this case. It completely shifted
So actually lets me segue sort of to my other interest in my other book about emotions, and that things that are laden with emotion, they are seared into our soul for better and for worse. And I think when we think about how we train people and how we get people to learn things, to think about how we package it, emotionally. Like take hand washing, right? We're always trying to get people to wash their hands when we put up signs and stickers and screensavers, and you forget it in 10 seconds. But imagine like you're on rounds, the big team is going into behind the attending. The attending takes their stethoscope, she's about to put it on the patient's chest, and then she whirls around and said, "What did I do wrong?" Right? Everyone's like kind of uncomfortable, shifting,
Yeah.
and someone's finally a student says, "You didn't wash your hands, and so why didn't you stop me?" And that kind of like sort of emotional moment,
Hmm.
you're right, because it points out without saying it that hierarchy is a
Mm.
leading cause of patient harm,
Of
right?
harm.
People are
Yeah.
afraid to speak out because of hierarchy. And by doing that with your team, in a way it's not harming anyone, but it sort of points out in this very emotional way why hierarchy can be so damaging.
So how then? Because medicine, and this is another area Michael and I talk about all the time. Like medicine is distinctly hierarchical, and I there's elements where it needs to be, of course, right? Like you need responsibility to stop somewhere, you need the buck to stop somewhere. Like that's all a true statement. How do we kind of break down those hierarchical walls while still maintaining what I think where people are afraid of, like frankly, a little bit of loss of respect, loss of prestige, um, wastefulness, people raising things that maybe they saw or don't think are important. Like, how do you try to balance that then, or even like inject that into the health system?
Right. I mean, I think again, it starts with people on top being more open about themselves, because I think that you can sort of earn your respect by being
Yeah.
honest, but also being really good. And I think that I don't think students, for example, will lose respect for an attending who is competent and caring, admits their errors. They'll probably still hold them in high esteem. Who is good to them, So I think it takes a little more. You don't get it just because you have those letters after your name. Um, so I think that we don't need to be so uptight about admitting our errors, our biases, places where we fall short. Even when something happens in the moment, to own up. I mean, this is I have a couple teenagers, and you know, you say and do the wrong thing lots of times. And if you stop right there and say, you know what, hey, I just that was not a good one. I own the responsibility for that screw up, and that kind of like sort of defangs the tension a little bit. And I think you
Mhm.
can do that, and not. In fact, I think you gain respect as a chief of staff or the chair if you will say that. And I so often see the opposite, like the doubling down on that, and it just doesn't get us very far.
Mhm.
And you talk about, I think other places, the emotional toll doctors take on by caring for patients. Can you talk a little bit more about how widespread that actual problem is and what you think is being done in a positive way to address it?
So for starters, 100%, right? Everyone has an emotional toll of that. I just came home grumbling yesterday to my husband. We have a new patient session every other week, and we've traditionally had 40 minutes for a new patient. But because of the overwhelming demand in New York City for people who need care, who are under or uninsured, and many new migrants and New Yorkers, demand is so high in the backlog, they've cut it to 20 minutes, which
Mm.
I understand why. But man, every single patient came. It was so overwhelming. And I couldn't finish with each patient. So I kept leaving one thing undone, going to the next patient and the next thing undone. And leaving things undone just undoes me. I like to be finish it, close it, I'll move away. I was starting to mix up patients. I really, I had 3 patients in a row with knee pain, but they were very different, but I mixed them up because I had the same chief complaint. Um, and so I think everyone feels overwhelmed by the gravity of what we do, because yeah, if you do mix it up, right, it's not widgets on a factory line. There are people, and I had one guy who came in. This is a new patient whose last A1C was 6, so he was pre-diabetic. I'm like, oh, I'll just check another one, whatever. It was 13.9. So in like overnight, in 1 second, okay, now he's a new diabetic and with really out of control glucose, like all systems firing. So, and this is the same 20 minutes, as the guy with, a little arthritis in the knee. And so I think we all feel, so I really do think it's 100%. The system is so unwieldy. The responsibility is so big. The stakes of, letting something drop are so large that we all feel it. Um, and sometimes we kind of lump it all into burnout, and kind of put it there and, oh, hey, you should take Pilates, you should, uh, do some resilience classes and that part, like, I don't need a Pilates class. I need an assistant. That's what I need,
That's
right? I need a
right.
secretary, or a massage therapist. But, it sort of puts it on, well, we just need to calm you a little bit down. And that's not really fair. Because just like with medical error, there's a system that makes this, so crazy. And part of it's the way we bill, what things bring in money, talking to patients, about eating broccoli and brown rice does not bring in money, but you know putting, if while you talk to your patient about broccoli, you put a tube into one of the orifices and you could pick any one you want, like the reimbursement's like 20 times higher, so we have this very procedure based thing. So, not a lot of time is given for, the cognitive side of medicine, and lots of money is given toward, I just saw an orthopedic surgeon get promoted to full professor. And I'm thinking, huh, that person just operates and does, like, nice person, smart person. They're not doing any like greater intellectual stuff than all my colleagues are doing. They're not being promoted to full professor. So it's kind of what's valued in the institution. The orthopedic surgeons, they bring in the money, they keep the lights on. I don't blame the institution for valuing them. They should all be valued, but not a lot of time for the real grunt work of, oh, let me talk to you about why you need another COVID vaccination. Like every single patient said, no, I'll get the flu, not the COVID. I'm like, all right, let's talk about this. It's really exhausting. So there's that part of it. Then, of course, there's the moral injury part, which I think is a really good term to identify the part of the things where the system pushes you to do substandard care, such that, well, you have to do twice as many patients and you cut corners. And that is corrosive to people. If you care about what you do, being forced to do a crappy job is about the worst thing you can do. You cut my pay, whatever, get rid of the coffee machine, fine. But make me do a bad job because of this is just excruciating. And that's when people say, I can't do this anymore. And so distinguishing those things out and really kind of putting some onus on the situation. I've written many pieces that, go here, go there, but the one that really kind of just keeps coming back and had a lot of traction was when it sort of dawned on me that the way the system holds together is that the professionalism of nurses and doctors, that is glue, because no one's going to go home until they'd finished their job. And the system kind of knows that, right?
Hmm.
So you can double the number of patients and I'm not going to go home. I'm not going to leave. So on my day off, I'm sitting in Epic and like following up on all those patients that I saw yesterday, because I can't not, like, that would be wrong. And it's sort of like this, it's elastic and ever stretching thing where you can keep doing it. And the doctor's never going to go home until the job is done. The nurse is not going to leave until the last medication is given. And so its system knows that. So you can cut back elsewhere and it's going to keep stretching, keep stretching, keep stretching.
Yes.
And that is problematic. And that's a system-wide thing. And offering Pilates is not going to cut it.
Yeah. I mean, I think, you're describing, as Michael knows, that he's had to listen to me be insufferable about this. I'm lucky enough to teach bioethics at Harvard Med School. And so one of the things that we talk about is responsibility and duty. And what you're describing for that elastic band is something that we discuss much smarter than people than me have described it. That's a one-sided ethical responsibility, right? Like the doctor has the relationship with the patient, the nurse has the relationship with the patient and to the work being done. And the system is ethically agnostic to it and just says, okay, like we can move this around like widgetry and we can extract more gain, more things like that. And that it absolutely, like, the only end point of that is moral injury, and then burnout, or whatever we call burnout, which I think we've probably already renamed or rebranded or something. But yeah.
Yeah, and I would actually go beyond that and say I don't even think it's agnostic. I think there are forces that work against it. I mean, we have market forces that work directly against that, right? There's more money to
Yeah.
be made, if we make that doctor call for prior authorization for every stinking time you want to get a CT scan for something. There's money to be made. And so that really is a destabilizing force that, it doesn't work in the same way that ethical responsibility does. Now, are there money grabbing doctors? Sure there are, but most people, listen, the people who went into medicine just to make money, it's much easier to get an MBA. It's 3 years. No one pukes on your shoes. I mean, why would you do
No.
residency if you could just do an MBA or even a law degree? It's much easier. You don't lose sleep as much sleep. So people who go into medicine at least are there because they want to do the right thing. Maybe some, get a little corrupted and some want a lot of money, but
Mm-hmm.
still, they still primarily want to do the right thing. And certainly you could say that for nurses. No one's getting that salary just to,
Yeah.
rake it in. So, so this is really fundamentally different. And am I gonna not check the potassium because, oh, there's like money to be? No. If it needs the potassium, I'm gonna check the potassium. I'm gonna stay until the result comes back.
Yeah.
It's just what you do. And what's sort of fascinating is to see how a lot of our society and government, that's kind of melted away. And I feel like we're sort of the last people standing, and maybe teachers who just sort of feel that way just
Mm-hmm.
implicitly. Like you couldn't not. How can you not? It's and you're the only one standing around doing that. Everyone else is like busy cashing out with all these things, and it is a little weird. But that's why I think there's still trust. I think certainly in nurses and to some degree in doctors,
Mm-hmm.
and I think in teachers.
Yeah.
No one goes into teaching for the big bucks.
You talk a lot about patient communication, how doctors communicate with patients. And you just mentioned all the work that the system puts on doctors because they know we care. They know we're going to do more and more as much as we have to. How does that interplay with the issues that doctors have with communicating with patients and problems that come up in that patient relationship?
A lot. So in this day yesterday, while I was running around with these new patients, every time I go to the waiting room, one of my patients would come up to me. This one woman came up to me and she was talking to me in Spanish, and it's not my first language. And so I'm trying to think, but I have all these patients waiting, and I finally said, I can't talk to you now. And I felt so bad that I kind of cut her off, but I really couldn't. And maybe I could have averted. I don't know what the problem was, but you know, so it just makes it harder to really communicate because so much of communication is just listening. And, when we listen more astutely and more acutely, I think when we talk about medical error, I think just the better listening, we'd make a lot fewer errors if we listened better.
Mm-hmm.
Certainly trust and communication if we just shut up and just listen. But it's really hard when you feel like you're being bombarded. And that's how I felt yesterday. And I think we all have those days more and more that you just feel so bombarded. You can't like take the time to communicate well and listen and be empathetic. So it really does impact that. On a good day, when the better angels are in charge, I close the door. I'm like, hi, how can I help you? Tell me about yourself. And it feels great. Like you can, especially when you sense that patients are in a situation in life where they're not getting much respect and they're being disrespected by society, by the people out front in the stores. And you can be, sir, ma'am, what can I do for you? How can I be of yours, in service for you, and give them some agency? Here's some things. What do you think we should do? What's important to you? That is just the greatest part about medicine. And then you walk away, particularly if a patient's walked in with a chip on their shoulder or angry, and you are able to
Mm-hmm.
diffuse that and get them to be your ally, and you've uplifted them and yourself in the process. That's to me, those are the big bucks. And I think we just feel like walking on air, and we've succeeded. We've helped a patient get past a stumbling block, whether it's with cigarettes or some addiction or anything that it is. It feels great. And so, you know, a- trying to make the circumstances conducive to that, it's very hard. And certainly overloading, clinicians makes it much less likely that we'll be good listeners and good communicators.
So outside of the system having a better allocation of work to doctors and practitioners, what else do you think drives change of how doctors can improve our communication with patients?
Study after study, shows, and the stats, the doctors cut patients off in 12 seconds, 9 seconds, 18 seconds. And and so doctors always verbally dominate any interaction that's ever been videotaped. But we do it even more so for patients who are obese, people of color, pregnant, elderly, disabled, you name it, any category of patients that struggle in our life, they have less talking time in the doctor patient interaction. So one simple thing we can do is just kind of like zip up for a minute. Like you say, the patient starts talking, you feel that first question, like, I gotta clarify whether, the chest pain is, with exertion. Just stop, zip up, let them talk. You know, um, I was always curious, how long would patients talk if we didn't jump in, And I remember asking my colleagues, like, oh, don't do that. Not the Puerto Ricans, not the Italians, you name the group, they'll talk forever. There was a study one study, and it was in Switzerland, that actually did just that. How can I help you? And the doctor said nothing till the patient came to a halt. And you know how long the patients talked? 90 seconds on average. Like, it wasn't the tsunami. Of course, those are the Swiss, they're diplomatic and precise. But I tried it myself. And the truth is, I did a day of like timing my patients. Even my most loquacious patient, within 2 to 3 minutes, came to an end. It wasn't the tidal wave. And I found that when I did it, my patients who were as we call the polypositive review systems patients, that's who like yes to everything. They have every ache and pain in the
Mhm.
book. And we all have those patients. And they're like, oh my God, I'm never going to finish in 20 minutes. I tried it with a patient like that. And surprisingly, it worked really well. Letting the patient just say everything on their mind, get it all out. The patient came to a natural stop without being cut off, probably the first time in known history that this patient got it all out. And I'm like, okay, I've got my list of 27 things. We're going to do 3 today. We're going to, these ones will the social worker, and it kind of like, it wasn't unending. It actually did come to an end. It was finite. It wasn't infinite. And that was this great relief to me. And then this patient said to me, just talking all that has made me feel better. And for patients like this who have so many chronic aches and pains, many of which are things that we cannot control, society, bad shoes, bad income, all these things, giving them the respect of hearing out, of bearing a witness, that in itself, and whether it lowers your cortisol level, your
Mhm.
stress level,
Mhm.
adrenaline level, all of those things up regulates your immune receptors, who knows? But patients walk out feeling a little bit, and then so did I. As I didn't feel like I was drowning so much. Like, and then there were fewer follow-up messages, phone calls, all things that I usually get with those patients who feel like
Yeah.
they're being cut off. So when I talk to my students about being efficient, and of course we have to be efficient. We're in a crazy busy system. Don't say anything for the first minute and a half. Full frontal listening, no typing, just listen to the patient, eye contact. It is money in the bank. And I think you'll make fewer errors because, the patient comes in and says, oh, I have this, pain over here. And we jump in on the shoulder pain, thing. They may have had a second thing to say, like, oh, I think I had a stroke last week, but we never get to that because we're busy running down trying to solve the shoulder problem. But
Mhm.
we cut
Mhm.
them off and we may be missing key important data that can help us prevent patient harm.
Your overall gestalt then is that this investment in communication right up front will pay dividends afterwards in terms of let's say the total episode of care you're providing this patient, right? It's not actually adding.
No, not at all. Both in the moment and in the long run. In the moment, if you establish that good, respectful bond, you have an ally for getting stuff done. Um, in the long run, I found for the patients where I'm able to do that, and I'm not always, but on my better days when I can, it just the number of messages that follow up, because I think we all know those my chart messages. There's a small chunk of patients that send a lot of messages for everything.
95% of your med.
Right, right. It's 5% of the patients, but kind of reassuring them, you know, and even just saying, if there's something else that comes up, you can let me know. But if it's a lot that comes up, we'll make another appointment. I don't want to give your concerns short shrift. And so if you message me a really big question, I won't be able to answer it well in the message. Save it for a visit or make a dedicated visit for
Mhm.
that,
Mhm.
and kind of trying to preempt all of that. I do think so. And also, I mean, what is the name of the game and what we do? We want to make our patients feel better. And there's so many
Mhm.
things that we cannot solve in primary care medicine. Just the world is too big and the aches and pains are too big. But if you can move the needle, even a degree, from when the patient comes in to when they walk out, you have succeeded in something. And
Mhm.
that, even if you didn't cure their illness, that you've made them feel better physically, emotionally, that is something of value for people. And I think we shouldn't underestimate that. And giving that extra bit of respectful communication really, I mean, think about it. When's the last time someone listened to you straight on for a minute and a half without, interrupting you? It's pretty rare. And it's
Yep.
almost startlingly, it's like someone just gave you a massage, psychologically, and you feel empowered. So I think it's a lot. And so I think the same thing for our colleagues and our friends and our partners, we, should do that as well. But for patients in particular, because there is a power differential, and that is not the same, let's say, with a friend, but with your patients already coming in, they're the one who's less knowledgeable, who's in pain, who's maybe less educated, or whatever the things they've been waiting for 3 months for the appointment, and you're the busy doctor, like you run the thing.
Mhm.
So if you can make them kind of elevate them, I think it really goes a long way.
I mean, Michael typically only gives me 17 to 19 seconds, so I'm actually kind of used to that. It's
On a good day.
on a good day. See,
When it comes to things going wrong, and things will always go wrong, who is going to sue you? Right? Because we're all afraid of lawsuits. And I think if you want to make an investment in trying to have it less likely you'll be sued, I think having a respectful, honest relationship that's caring and empathetic. I had a patient where a disastrous thing went wrong. It was a snowball effect of everything. And I advised this patient to do the procedure, and it was a nightmare. And so when I spoke to him, I finally said, I would certainly understand if you want to change doctors. Like, I don't know if I want to let you know that's available. And he wouldn't hear of it, you know. And I think coming and telling him and we had this long relationship, really, like, he understood that, you know, an error can happen, but your doctor isn't necessarily the error. And that's a distinction that often isn't made, both by the patients and by the physicians, I will say. But helping a patient understand that you are meaning well, and something bad has happened, they may not put that thing quite as one on one if they understand you as a human being who's respectful, who treats them well, takes them seriously. So I think there's so many things that come out of it. Plus, it just makes it more fun. It is pleasant. You're with someone who's not angry at you and who's enjoying it. I mean, in that day yesterday, which was crazy, I had one patient, the one with the new diabetes. We were laughing. We were able to like connect and be self-deprecating. It was so nice. And we went through like the ringer yesterday, but we managed to establish a pretty nice rapport. And I think we couldn't have done all that, you know, if it had been contentious in any way.
no, absolutely not. I mean, it's that maintenance of that physician-patient relationship, right? It is all structured around communication and the strength of the communication that you're able to bring to that moment. And I think what you're speaking to is some of that like authenticity as well, right? Like you're able to be self-effacing or self-deprecating. You're able to bring out the best in their customer and frankly take some of the air out of the room, especially in a case where that's a surprise that the A1C went to 13%, right? That immediately starts conjuring up a lot of stress, frankly, in you and the patient at the same time about what's going wrong. So being able to bring that humanity to it is critical, right? Like being able to address that one-on-one with the patient.
And I think the same holds for your learners. When you're the top dog on the medical team or the department, I think the same thing, works. Obviously appropriate for that, but you can be respectful and honest and admit when you don't know and
Mhm.
when you're unsure, when you're nervous or scared. I think that actually, enhances. I have one amazing, chief of service who's been like that. And I'm thinking about all the bad news he's had to deliver to us as faculty, salary, whatever the position cuts, all these things from someone who already was like in it with us and had our respect. We would do it. We would do anything for him. He's like, I need you to
Mhm.
work overtime. We would do it. And I know other, chiefs of service who would not have gotten that response from their faculty because they didn't have that genuine respect, and empathy built in.
Can I ask about communication? And this is a relatively newish issue, but how do you, maybe even yourself, deal with the potential of miscommunication now that patients have greater access to our records, our notes that we're drafting, history or progress notes or labs? I mean, there's a lot of issues there that maybe we weren't having to navigate in the same way, say, even a couple of years ago. How are you navigating that?
Well, funny you should ask. So I ended up writing a piece for the New Yorker on medical transparency because I was so torn about this. The idea of transparency in theory, we love transparency. But actually, full transparency isn't always good, right? There's lots of places where full transparency actually works against things. And we can certainly see it in medicine. So, an example, now that patients get their labs before I even see them, and of course, when you have a panel of labs, like a basic metabolic or a CBC, there's going to be 50 values, right? Half of which are generated. And of course, one or two of them are going to fall out of the little thing. And in our system, it's bright red, blood red with yellow, garish yellow around it. So like you can abnormal with 3 exclamation points. So it scares everyone. You know, I've gotten more emails about chloride being out of whack than almost anything else because the chloride's always out of whack and is we completely ignore it, but the patients don't know that. Or um, the chloride or the MCHC, there's two values
Mhm.
that just keep coming
Yeah.
up, and people like research. I've had patients Google chloride levels, like, oh my god, can I list the diseases? So it's not, especially for the hypochondriacs. Oh my goodness, this amount of transparency is not good for them or for their doctors. So there's that sort of, it's like explaining, educating, again, more burden on the doctors to explain the system. What's really difficult, and I think unconscionable, is when a patient gets a serious diagnosis from the portal. And I've had 2 patients see malignancy related things in a scan report before I got to them. And you know, I know there should be no information blocking, but I think I wouldn't want to know about my cancer through the portal. I want my trusted doctor to be talking to me. Now, maybe some people do want to do that on a Saturday night, learn about their serious disease. I think very few. And so I think there's some things we can do. Because then the other thing is, well, then there's no vacation. Like, you have to be, those breast biopsies come back on the weekend, the patient sees that and they don't understand what a fibroadenoma is, even though that's a benign thing. It certainly sounds like a scary thing. Have you ever looked at an L-spine CT, report and not think you're about to be paralyzed? Like everyone has something abnormal in there,
Yeah.
spondylolisthesis and,
Yeah.
onychomyomia, it's terrifying. So it becomes more exhausting now for clinicians. So that's, again, a systemic thing. We've now made, transparency. Now you doctors figure out how to pick up the pieces. So another one is professionalism things. I try to educate patients. I do now have a dot phrase about how many things look abnormal but are not actually abnormal. If something is seriously abnormal, I will call you, which I don't put all the time. When patients write in about that, I have that, ready.
Mm-hmm.
So it is a very mixed thing. On the other hand, for some patients, it is very engaging and activating. They can see, how their A1C is. Oh, I gotta, I called the patient about A1C and she already saw it. She's like, did you see my A1C? It was so great. And, so it can be for the right patient, I think, for some patients. And then, of course, there are other issues, who has access, what about someone in an abusive relationship where, are they going to tell you things that are now going to appear in the chart, and, who knows who's accessing the chart? Imagine someone in a domestic violence situation, someone gets their password, or knows where they are. There's all kinds of things. I have, at least, in fact, I have this father and adult daughter relationship. The father is an immigrant and his English is modest and he's not much. So the kids handle the electronics. So he does not want his Viagra in the chart. So his adult daughter, so it's off the chart. I handwrite a prescription. I just keep it in my head. And then she came in and she was asking about birth control, and she's unmarried in a religious family, and she doesn't want her father to know about that. So I'm, keeping everyone's, privacy and secrets, but who knows who can access what in the chart. And so there's things like that. Some patients react very negatively to the way the diagnoses come up. You may
Yes.
put BMI of 35 and it says morbidly obese, and that
Yes.
is insulting and terrifying. You say about a patient who has issues of depression, well groomed, which is a term for us that they're doing pretty well, but like, grooming, why are they commenting on how I'm appearing?
Yes.
Or maladjusted. So many things so it does change how I write. I now think, patient's going to see this. So I write a little bit less in my notes, and I'm a little bit sad about that, but it's not worth it. Someone's going to get upset that I described, how they look, and I just leave it out.
We were counseled after the Cures Act came out to write with the assumption that the patient will read everything and that they should be reading everything and we should write to them. And so our group kind of made some of that shift initially fairly early on. And then pretty early, we're like, well, now we're not communicating with each other anymore.
Right.
Like, there's lay communication and then there's professional communication. And we've really kind of broken down, like, we were all trying to figure it out, right? This was a wild thing to drop on us in the middle of COVID. Was now trying to figure out probably one of the largest structural changes with patient access to healthcare records in, I hope, my career, our general careers. And we swung really hard in one direction, and really early, we're like, I have no idea what you did last night. I don't, I have no idea what plan that was. I could look at the MAR, I guess, and go look up medication administration to try to back in, but like, I've lost your thinking and your thought process. Yeah.
I mean, the patient may own the chart, but the chart is there for the clinicians to communicate. So I write in my way to communicate, and if they have a question, I'll clarify. It's too exhausting to rewrite. I mean, I definitely think twice if language might be interpreted in a way, like, what do you do if you think a patient is malingering? that
Yep.
type of thing. I might not write that in quite those terms.
Yep.
Um, but I might say, unclear if there are organic causes that might, explain this patient's symptoms as a way to let the next clinician know. And myself, I rely on my notes. Next time I see the patient, I need to know what I'm doing and why I'm doing it.
Yeah, I mean, there's only so many like off-book prescriptions you can store upstairs, right? Like like at a certain point, like there has to be the actual cataloging component
Right,
of it because
right.
you can't be expected, especially on crazy clinic days like you just described yesterday. So,
It just occurred to me, Dr. Ofri, that as an internist, sometimes we get comments about how lengthy our notes are, but it probably lends itself well to someone who's written 6 books and writes for the New Yorker and New York Times to be able to write and be so clear. I'm guessing there's less surgeons that write 6 novels than there are internists, but I haven't done the math. That would be an interesting study.
Well, I'll say there are probably fewer surgeons, not less.
Oh, there you go.
oh,
Shoot.
and with
Right.
the English lesson
That
too. This is
that
this is the best day.
that was my pediatric side that spoke
Right.
there.
Yeah.
Sorry.
Well, that gives me the chance to bring up Bellevue Literary Review, right? So in my other side of time is editing. So we correct less and fewer all the time when we're editing all like the beautiful poetry and fiction. That is what we do. So being precise with language, both in the medical chart and on the literary page, is so important.
That's
That's
great.
wonderful. That's wonderful. Thank
That
you.
made Ned's day.
Oh, year? I don't know. This one is getting this is fantastic. So
Well, Dr. Ofri, we're wrapping it up, but we always ask our guests one question at the end of the interview, and it's because as doctors, we consume lots of data, lots of information. We have to think on our toes and change our perspectives. But I would ask you, what is one thing that you've changed your mind about recently?
Well, I was thinking about that. There's lots of like, little things I've changed my mind on, but one larger thing I think I've changed my opinion on is bariatric surgery. When it first was coming out, I'm like, ugh, pshaw, that's ridiculous. Why are we surgically correcting a problem that we've created societally? It's obviously
Mhm.
that's crazy. But as time has gone on, and I've seen my patients get really good and sustaining results, and because there can be a virtuous cycle when they lose weight and they feel good about themselves, it's easier then to exercise and do the right things because they feel that, and I guess the same thing could be said about the GLP-1s, the Ozempic,
Mhm.
Trulicities.
Mhm.
um, it wouldn't have been my first go-to, but I've really seen some transformative things where people really walk away and feel like they can now take charge of their health. And so I am more comfortable, recommend, of course, more data, and obviously we see some mortality benefits that are intuitive, but it's nice to see them actually shown. So I've really changed how I talk about bariatric surgery. It's not my first line treatment, but I'm a little more confident in my patients that this is really something that, even though I still think it's our societal problem, our portion sizes, big ag, all these things are high fructose corn syrup, our Doritos, all the things that we've made food addictive, and the price of soda versus the price of milk and all these things, but we can't solve those so quickly. I mean, but this is a way for the individual patient who can, for the right patient, can really be helpful. So I've changed how I feel about that.
That makes a lot of sense. Thank you for that. I wanted to see if our listeners wanted to follow you or find out more about what you're doing. Where can they find you?
Sure. My website is just danielleofri.com. And all my writings are there. I do a monthly newsletter. And then I'd encourage them to check out Bellevue Literary Review. We have a website, blreview.org. We have a newsletter. We publish this great issue twice a year, paper, and also comes out in digital. We have events online, in-person events, things with dance and poetry. We're doing a live storytelling event, lots of sort of creative ways to think about health, illness, and healing, because I think we read a lot of journals, we read a lot of textbooks, we read a lot of notes, and there's something, very limiting about that, because there's a lot you can tell about, the patient's disease process, but about their experience of illness. There's so much more that we miss in our very limited way of looking at writing and information. But using fiction, poetry, and creative nonfiction, you can really dig into the many other aspects that are equally crucial. I often say that patients often walk out of our offices, cured but not healed. And there's a big difference. We can cure a disease, some, not a lot, but a few, but they can still walk out not feeling fully healed. And that takes some other aspects. And I'll tie that also into our conversation earlier about ambiguity and uncertainty. How we grapple with that is really critical to how we become good clinicians. And so the creative arts really specialize in helping us deal with ambiguity and uncertainty. So I recommend literature for that. And Bellevue Literary Review is a great way to get some.
Wonderful. Well, thank you for sharing. We'll definitely check it out. Dr. Danielle Ofri, thank you for joining us on the show today.
Thank you. It's been a pleasure.
Thank you, Dr. Ofri. What do you think, Michael?
I thought that I need to work on my grammar.
I learned that too, and I'm thrilled to continue to call you on that.
I doubt that you just learned that I need to work on my grammar. I still don't understand commas and a few words, but no, she was amazing. Look, I mean, you in medicine and healthcare, there's a lot of really intelligent people, and then there's folks that are kind of next level that bring a lot of other skills to the table, and I think she is definitely in that category. When you think about bringing in really complex concepts and being able to communicate those, whether it be verbally or the written word, where she really seems like she thrives.
Absolutely. And I mean, I really think it was such a fascinating conversation because she has that clinical background and the clinical chops of being an internist at Bellevue, the oldest hospital in the country with its own, gosh, how many books about healthcare have been written about Bellevue, good, bad, and ugly. And then bringing the topics that she is, ethics, humanity, like really almost like the philosophy layer that underpins medicine and how we practice every single day, how you choose medicines, how you choose interventions, even your direct patient communications and the way that we talk and communicate to the next generation of doctors that we're kind of constantly looking to train and bring up.
It also is encouraging because we're all individuals as doctors and we have, like I said, these other skills. And it's cool when you see examples of how people bring those other skills into their job. And it's not just I see patients and I write notes and do surgery. It's like there's other ways you can bring those skills and really lift the I think doctor community and therefore patient community up. So I think she's a great example of that.
Absolutely. And I think we were lucky to speak with her. Given how busy she is, given how many books she's written, I am blown away and very humbled that she took the time to spend more than an hour with us talking through kind of her current writings and what she's going to be working on. So thank you for listening to the podcast for Doctors by Doctors with Dr. Michael Jerkins, Dr. Ned Palmer, and today, Dr. Danielle Ofri. Thank you very much.
Thanks for joining us this episode. You can catch the podcast For Doctors by Doctors on Apple, Spotify, YouTube, and all the major podcasting platforms. If you enjoyed this episode or learned anything here today, please take a moment to give us a rating and subscribe so that you don't miss a single episode release. As always, thank you for listening. The next time you see a doctor, maybe you should prescribe this podcast. We'll see you next time.